So you can start.
I can start.
Okay.
I'm actually.
So it started. Thank you.
Yeah. Okay.
Okay, it's 4 o'clock.
Yeah.
We have 12, 13, 14. Okay. If you give it 1 more minute. Yeah, I saw some of our department faculty are joining in now. Okay, so let's get started. Okay. Good afternoon, everyone. Welcome to Penn State CTSI BERD Seminar Series. My name is Lan Kong. I'm co-leader of the BERD group at College of Medicine. So I'm hosting this seminar with my colleague Jinjia Jay. We are both from the Department of Public Health Science. So for those of you who joined us for the first time, I would like you to know that this seminar is being recorded. All the attendees are muted. So if you have any questions, please use the Q&A box at the bottom of the screen. The chat box will not work. All the presentation slides and the recording link will be available after the seminar. After you finish the seminar, you will be asked to take a short survey about the seminar. We appreciate your feedback and suggestions. Well, now I'm very pleased to introduce our seminar speaker today, Dr. Vida Abedi, who is my new colleague at the Division of Biostatistics and Bioinformatics. Dr. Abedi just recently joined the Department of Public Health Science as an associate professor. So Dr. Abedi has been trained in biochemistry, molecular and genetic medicine, bioinformatics, and computer engineering with interdisciplinary skills and experience in machine learning, big data analytics, multi-scale modeling, electronic health record mining, and text mining. Before her joining the Penn State, Dr. Abedi has been an assistant professor in computational biology at Virginia Tech and research associate professor at the Weiss Center for Research at the Geisinger Health System. She has extensive experience in applying artificial intelligence and machine learning to biomedical research, especially in the areas of neurology, nutrition, immunology, and infectious disease. Today, she will share with us her experience and expertise in AI application for clinical research. So Dr. Abedi, please take it away.
Thank you so much for the introduction. So without further ado, let me jump to the slides, and so we can have more time for the questions at the end. I usually try to not make it very long, but I end up. So let me share the right one. So do you see my screen?
Yes.
Yeah. Okay. So the talk today is on the application of AI for clinical research, and a lot of examples I'll show they are coming from the past 5 years working in Geisinger with a lot of work that has been going on. I mean, it's a teamwork. It's not, I don't get all the credits, but by working with epic engineers, programmers, clinical geneticists, and so forth. So this presentation is coming through from a collective effort. So AI, I was thinking about that when I was preparing it. So AI basically is in our everyday life now. Basically, Netflix knows which movies we are going to watch more, we prefer to watch. And Amazon knows which items we are going to likely buy. So it recommends those items to us, and it has personalized our experience through the use of AI and advanced statistics. Also, Google knows which symptoms and conditions people are searching for, and that can be used to predict the frequency of seasonal variation of flu, of many other epidemics, and so forth. So this is nothing new. And there is a lot of data that is been, in our EPIC system or in our clinical records per se, and these are waiting to be mined. We can use the data to facilitate analysis of imaging medical images. We can correlate symptoms and biomarkers with the prognosis of a disease. We can optimize, for example, clinical or administrative workflow. We can also try to improve the clinical documentation and outreach. So there is many more examples. We can also improve patient monitoring and tracking and post-treatment and so forth. But how long has AI existed? I mean, this is a buzzword nowadays, but AI is, or machine learning interchangeably is used, even though it seems a new trend, the origin dates back to the 50s when Alan Turing developed the Turing test, which was an exercise to test the machine's ability to exhibit intelligent behavior equivalent or indistinguishable from that of a human. And since then, there was a lot of progress in this field. And now with stronger computational power and larger databases that can be mined, we can see the fruit of that. So in healthcare, essentially, the goal is to improve our ability to make a medicine a precision medicine or personalized medicine, make this a anticipatory medicine, some people call it, which means that we want to predict what will happen and how to react with that information. But over the next 10 years or so, there is a lot of effort that is going to be in place to ensure that there is more diversity and inclusion in the patient representation, making sure that we have large and longitudinal cohorts, and ensuring privacy and trust and return of value. Of course, we want to start including other type of data set with our clinical records coming from environmental, all these wearable technologies, and making sure that whenever possible, we can integrate genomic information. Of course, the ultimate goal is to go beyond clinical data to introduce physical activity, reports, microbiome, diet, and everything else to have a more global picture of one's health status. And it is not surprising that there is a huge number of startups that are coming up with ideas and starting companies. So the number of companies implementing AI-related technology has grown over 200% over the past few years. And it's just very difficult to keep track of things. There is every idea that you can think of, there is a startup or group working on it already. So I will explain some of these examples and also introduce mostly some of the challenges and a workflow pipeline. Just our group, we start looking at the past few years, current examples that, in healthcare and AI, what everyone else is doing more systematically. So we looked at cardio and cerebrovascular condition in particular and the use of AI in this field. So because there is so much and there is so much more has been done in more recently, as we only focus on the past 3 years, 2017 to 2020, and we identified over 500 articles. From that, we looked at about 70 or so larger studies. And these studies included an array of clinical application ranging from risk stratification to diagnostic studies, to outcome prediction, treatment strategy, diagnostic imaging, and so forth. And the review article is actually in press right now as JCM. So if you think about acute disease such as a stroke or heart failure or infection or COVID, there is different levels of prediction that we can think about. So ideally, we want to try to have a risk estimation, profiling, care gap identification to develop a primary prevention platform that is driven by data and the historical knowledge about the patient, especially in the condition that affect at the older age, and there is enough preliminary results or data from that patient during the early stages of their life in the healthcare system. Our pre-diagnostic model for primary prevention. In the case that we want to target acute phase, we can think about the EMS referral, we can think about acute diagnostic, acute imaging, triaging, treatment, and these are going to be using quasi-real-time data. So it's more challenging in terms of implementation because the data has to be streamlined, analyzed, mined, and the prediction ready, available for the clinicians or providers to act upon. And sometimes, a lot of times, we are too late, but we can still intervene for secondary prevention, make sure that we have personalized treatment, or we can predict the outcomes so we can have a proper education or outreach and patient monitoring in terms of post-diagnostic modeling. And finally, there is the rehab part, post-diagnostic modeling as well, but this is targeted at personalized treatment in the long term, and again, outcome prediction for during the rehabilitation process. I thought about this presentation a lot, and I kind of made one, and then I wasn't really happy. So finally, this is kind of one idea to kind of walk everyone through my own experience in the pipeline, in the design, development, validation, implementation, and monitoring of the AI-enabled solution in healthcare. Every stage is as important as research question, for example, is very important. Same is the sources of bias, and same goes with the evaluation. So every stage of the process is important, and it's really critical to think about the big picture before we focus on a specific, we think about the data, we have to think down the road, what would be the downstream analysis that will need to happen, given the sources of data that we have. So I'll go through each of these and then show few of our examples that we develop in our team. So the research question may be a trivial item, but I think is one of the most important aspects in terms of developing AI solution for healthcare. One may think that, this is a cool idea, but then we have to think beyond the initial intuition. We have to make sure that we are aware of the guidelines, and the guidelines are stable, and there is the end user are consulted. That includes sometimes ED primary care practitioners, nurse navigators, and what are their expectation, and what is their what kind of solution they are looking for. There is also a system infrastructure, EHR engineers and innovation team. They have something else in their mind, and sometimes the expectation or the limitation in terms of implementing something can have a very different who you talk to. And of course, we want to make sure that we have the leadership support and the ideas aligned with the overall goal of the institution. And it's not only the end user that are impacted, it's also the next provider. So in some fields, the clinical workflow is not always straightforward, and it's really important to have open communication with the providers, and not just with one type of providers, but in the workflow, we are aware of the whole process before we implement something. So once we know the question we want to target, and we are aware of the overall big picture, we have to come up with the phenotype definition. And this is not only about the case, and it is as important to have a clear idea of the control group as well. So these are 4 examples here that I kind of, based on our own research in the lab, listed here. And so the first example is, let me just introduce these 4 or 5 projects. So the first project we started at Weisinger about 4 or 5 years ago was predicting a stroke in emergency department. And this is basically a real-time project. So patient comes to ED, we want to use as much information as possible and flag the patient who are likely to have a stroke. And this is important because there is a very narrow time period from the time of onset, last seen normal, to the time that we can actually intervene and give the medication to unblock the blood vessels. The second project is predicting septic shock in patients with sepsis. There is a lot of challenges in this study, including the always changing phenotype. There is the SOFA definition, and then there is ESOFA, QSOFA, and so forth. So there is always evolving. In this case, the cases are sepsis patient progressing to septic shock within a defined time period, and the control are sepsis patient not progressing to septic shock. In the third example, predicting C. diff infection. So C. diff phenotype is actually an interesting phenotype because it's not just based on ICD code. There is a clear published phenotype definition that we can leverage and use that to define our cases, which are the C. diff positive cases, and control. Those are the patients who have been tested for C. diff, but they have been tested, the result is negative. And finally, there is outcome prediction models, including the prediction of post-stroke mortality and the predicting of 30-day readmission. And the stroke phenotype can be defined by a combination of ICD codes, duration of hospitalization, and brain imaging. In terms of a stroke, because it's a very important condition, and people don't just put the code in. It's not like headache or some depression. Those are more challenging. So the ICD code has some weight And but then there is also the duration of hospitalization. In some cases, the patients get the ICD code for a stroke, but if they are discharged quickly, then that was the initial intuition of the physician, but they probably thought that that wasn't, it was probably a stroke mimic or a major headache or seizure or something like that. So we also included brain imaging confirmation to include in the cases. And then we can define the controls if they are alive, the status of the patient within 1 year or readmitted within 30 days and so forth. So I don't know if there is any questions, or I can just, yeah, so far no question. Okay, so the phenotype definition for C. diff. So there is a nice resource, is the phenotype database, VKB. And whoever is working in this field, you know, I encourage you to go check that, because there is a lot of condition that there is a lot of literature on how it was defined, and very clear roadmap to come up with the various, you know, validated phenotype definition for the condition of interest. For example, for C. diff, this is kind of, you can say it's not a straightforward, but there is the literature supporting it, and different centers have developed these phenotypes. And sometimes we don't have the luxury of having these existing phenotypes, so we have to work with the clinical team and the EHR engineers, or, you know, EHR modelers to design a solid phenotype for our case and control. Okay. So the next thing, once we have our phenotype, we have our research question, is thinking about the data sources, data type. So there is, of course, the electronic health record. There is also the claims data. We can look at the unstructured data in the clinical notes. Depending on the condition, it might be useful to have access to those kind of resources, and depending on the healthcare system, accessing and mining those kind of unstructured data may be more challenging. There's also the imaging that has to be de-identified, so there is no data leakage, and has the privacy of the image, especially when there is a facial image. It becomes important to have a proper de-identification process. There are also external sources. For example, for mortality information, the electronic health record has to be mapped to the mortality information from CDC and Social Security databases to make sure that we have the status of the patient if they have deceased outside of the healthcare system, and to make sure we have that information. So in case of the stroke, for example, we used the electronic health record and triage notes, so we had to do NLP. In terms of the septic shock study, we used the clinical notes as well for our definition of sepsis. And we, of course, used the electronic health record. For the infection, C. diff infection, we had to use a lot of medication data and claims data to really confirm the diagnosis and the risk factors, high risk for antibiotic use within a certain time frame from the infection to identify high risk versus low risk. For the outcome of mortality, we had to rely on the data from CDC, which is synchronized with electronic health record to make sure that we have the outcome of interest. I see there are some questions, so maybe. Yes, so one question is, I have a question on the example. So those are indeed classification problem. So classification, yes, you can think about that as a classification problem as well. So longitudinal data, that's a good question. So in terms of data, when we look at, so the challenge with EHR data is not synchronous. So we wish we had exactly at the same time for everybody, but a lot of time is really all over the place. So we have to create windows to make sure that we basically reduce the selection bias. And if our window is too narrow, then we really have very few patients. If our window is very large, then we have a lot of noise in the data. So, so that becomes a kind of a part of the research questions and how we are framing the questions. So Cerner or EHR, for EHR, so we had EPIC, we had access to EPIC, and the EPIC was basically copycat in a de-identified data warehouse that we would query, a MySQL database that we would query to extract the database, to extract the variable of interest. Okay, so let's go back to the next stage. Okay, so for example, the sources of data. So this is an example of a note that we parse and extracted useful information, optimize the keyword of interest, and basically develop our case control, make sure that we have features that are representative. So in this case, a patient present via EMS with CO weakness starting last night around 1900. The patient stated he's also experiencing numbness and tingling down both arms into the hands and fingernails and or shoulder blade and right shoulder blade. So first of all, this is based on a CTEX pipeline that is already published. So the algorithm to that basically get the part of a speech tagging, dictionary lookup, entity recognition, and these are already built in. So we use something that we don't want to reinvent the wheel. We just customize it to our own needs. So there is a part of a speech tagging, and then we basically have selected 55 different dictionaries, including ICD codes, OMIM, GEO, MESH, and so forth, to identify different entities, and then have, for example, even entities have different characteristics. So entities about time, entities about science, generic, and then there is also the negation. So if something says did not have weakness, then we would have a positive or negative keyword. Then there is like 10,000 different keywords that come up when you have all these triage notes. And the question is, do you want to really have 10,000 different quiz concept identifiers as feature set? The other idea is to actually optimize this process and optimize the quiz selection that we did by, that was another algorithm on top of the quiz. And this is basically showing a subset of the concepts in the cases and controls. So some concepts come more frequently in the cases, and some concepts come more frequently in controls. And this shows that our classification or prediction model, if the keywords are really representative of the case and control, we can use it to improve the prediction based on the initial notes. And then that leads us to the sources of bias and noise, and what tools and techniques we have at our disposition to try to address some of these. Level of missingness in the data is a major issue in electronic health record mining. There is a lot of noise. Some of it is you would think, some of them you don't think about it, and every time you get another surprise, which is no surprise, but it's a surprise. And then there is also the presence of redundancy that can help us sometimes. For example, claim and EHR data can complement each other to improve the accuracy of the information. So for example, if I go back to our 4 examples, in prediction of a stroke in ED, we had a lot of labs that had missingness. We had a lot of noise in the notes, and we didn't have historical data for new patients. especially for the younger patients or for patients coming to the region. In the case for septic shock, we didn't have all the data we needed at the time of interest. And that's why we look at different prediction window. And again, lab values are missing in every project. For C. diff, we had medication data is very challenging to work with. You don't know if the patient got the data, medication, if the patient actually used the medication. So there is a lot of assumptions, and you have to kind of go through the whole process exercise to have a more pragmatic view approach to do that. And for the outcome prediction, when we are looking at mortality, the updated patient status can be a little bit noisy depending on the time frame of interest. So let me give you an example of one of the surprises that we had. So we were looking at lab values, and I remember this was a hormonal value. So we had this distribution. So this is the X represent the values, the Y is the number of records, and we say, oh, nice, it looks as if there is a bubble. So it seems that there is some patients that have higher and versus lower, and the range is acceptable. So we are good to go. So we kind of, but then we kind of thought maybe we should look at a bit more in terms of the values. And out of a sudden, when we plot the distribution over a time frame, we see that over the first 4 or 5 years, the box plot shows that the values range from such and such, and there is some outliers. Then in about 10 years in the middle, we have the values that are 1,000 times smaller. And we kind of dig in a little more. So it seems that during this time, 10-year period, the kit that was used in this lab was changed. So the milligram, millimole, all these units kind of shifted 1,000. And that was after quality control. So we kind of bring the values to the right values, so right unit. So these are simple things. If you know it, it saves you a lot of trouble. But then how do you know it? You just have to dig in very deep into the data before you use it to do any prediction. So the missing data is also very challenging, and this was actually published very recently. So I thought to just put it down here. Still today, with all the technology, with all the available resources, there's a lot of tools to address the missingness, but still today, the majority of the papers don't even talk about missingness in their data, and they perform a complete case analysis, which means that whoever has a missingness in, for example, A1C, they kind of don't use that patient, and they only focus on the patient who have the value, which causes a very major problem in these prediction or classification problems, because we are only focusing on the very sick patient or the patient who actually have the data, they have insurance and so forth. And so this is a major issue still today. So what we looked in our cohorts, we look at 3 different cohorts: IBD patient, inflammatory bowel disease, osteoarthritis patients, and also C. diff patient. And we wanted to see in general, what is the patterns of this missingness, or what is the pattern of the frequency of the labs in these patients. So, I mean, there is a whole description of these frequencies. The bottom line is that there is a lot of labs that have more than 50% missingness, and these are not very unusual labs. These are A1Cs, more than 50% missingness, iron, THS, thyroids. So these are very important labs that have very high missingness. And these are not frequently ordered as well. So it's really important to know what we are dealing with and kind of try to address that. So what we did was, I'm going to skip a couple of these slides because I want to kind of be able to go to the end. So what we did was to really go deep and then better understand how we can impute the missing value for electronic health record lab data using two different cohorts, one from Geisinger and one from Sutter Health, California, looking at the top 40, 50 labs and basically developing a benchmarking and practice recommendation for the labs that have high missingness. Prediction models. So once we have our data, we address all this missingness, we make sure that we reduce the noise as much as possible. Then we are ready for our fun part, which is building the model. So of course, it's not just about building a classification model or prediction model. Is about building, evaluating, performing sensitivity analysis, stability analysis, performing subgroup analysis, and so forth. So it really needs to be massaged and look at different angles to make sure that we are not introducing any bias or we are not ignoring any cofactors or mediators in the model that the prediction may be, we thought we discovered something, but it's actually the data that is not well represented. So going back to our 4 examples. So for example, the prediction of a stroke in emergency department. Of course, we've applied this machine learning, the classical machine learning to the structured data. We have to adjust our NLP and the features coming from the notes and apply modified version of these models to the clinical notes. So we built 2 different models that are complementing each other. In case of a septic shock, we again apply these machine learning models to a structured data, and we look at different prediction window for different level of data availability. For the C. diff, again, the same process, we apply this machine learning, but in this case, we had genetic features. So we really wanted to see if the genetic features plays a role. And then since people enrolling in biobanks tend to be more healthier, they have health insurance more often and they visit the hospital more regularly. So we saw that actually that comes up in the model. And again, when we analyzed age and sex stratified patients, we saw that some of these effects would disappear or becomes less prominent. So for our outcome prediction model, again, we wanted to, one of the important aspects in those models was to identify the features that were driving these models, this prediction, and make sure that they can be, they make sense to the clinicians and we can find something that can be actionable. So in our prediction of a stroke in ED, for example, we identify 5 cases that were missed in the hospital. And these were from a quality improvement group. So these were the 5 cases that they should have got based on the patient, when patient comes, so they were, and then we applied the models on those 5 cases. And we show that what would have happened if this machine learning was in place. Would the machine learning been able to flag the patients or not? So this is additional adds on to the actual prediction models to kind of evaluate what would have happened if we had this in place. In terms of the CDI, so the research question was that does including common variant with a small effect in the model would improve the prediction? Of course, we show that the improvement is marginal, and basically when we applied propensity score matching for sex and age, and then this becomes marginal. Again, we also saw that the patients who had genetic information had better outcome, and that's kind of something selection bias that we always have to be careful. So it's really important to perform subgroup analysis and really know what we are jumping into. So let me move to the next one. In terms of the sepsis study, we had 45,000 unique inpatient visits, so the data was really large. We wanted to see if the clinical variables could be better suited, or billing information could be better suited for the prediction models. We saw that billing information can be used, but clinical information coming from the notes as well as the EHR system, the structure system, have a better ability to improve the prediction. So we really did a lot of different models, different sampling, different detection windows. So the model optimization was very exhaustive. And the feature selection also was not based on what we would like to put, but based on what would be available in the clinical workflow. So initially, I think it started with 50 different features, but at the end, it was 8 or 9 different features that was selected to be in the model to make sure that these variables are available when they are needed, and also they make sense to clinicians when they see it. So the model interpretation was very important for us, especially since there is already a sepsis flag in a lot of healthcare system. And from what I heard, every six patients that are flagged, only one is really sepsis. So the alert fatigue is really discouraging practitioners to use the system. So we really wanted to be careful about that. So for the readmission study, the outcome study, we wanted to make sure that the feature importance made sense to clinicians, and when we show them the features that come up in our model, kind of was interesting for them, and that was nice, because there is a lot of prediction of readmission work, but we believe that this has to be really targeted for a specific condition. Readmission for a stroke patient is very different from readmission from heart failure or other major events. And these features really showed that some of them are really targeted for a stroke, post-stroke outcome. So now we build our model, we tested it, we did all this additional analysis, subgroup analysis, propensity match scoring, and whatnot. And now we want to, we are ready, we are excited, but then we have to think and make sure that we have a validation strategy that really takes more than one healthcare system, one model, and move to the implementation. We want to make sure that we can have a secondary validation, even at least prospective validation. Better to have external validation from a different healthcare system to really make an impact in the field. The field of AI is moving so fast that it's really hard to keep up with the FDA approval process. So, and that's important for some models. There is always legal consideration. A lot of these prediction models that we, risk stratification at the population level, especially for preventive measures, primary prevention, and so forth. So they are really not posing significant risk to the patients. So they don't really need FDA approval, but in some cases, it might be important to look into it. And these things are always evolving. So it's really important to be up to date when there is a plan to start implementing some of these things. And we move to the implementation. Real-time data access is really important. Of course, it's always more easy to use a primary prevention project, so we can use the retrospective data. We identify the patients, we try to educate them, we bring them in for additional tests. But when we are talking about sepsis or infection prediction, or in ED, prediction of a stroke in ED, we need to have real-time access to the data. And a lot of time the EPIC or CERN, I'm not too familiar with CERN, but a lot of time it's really hard to get that data at the time of at the same time in real time. So a lot of time, next day data becomes much more available and flexible to use for predictions. So these are the things that we really have to talk about before we go, design the stage. So make sure that this is doable when the time comes. So in our prediction of a stroke in ED, we kind of had this pipeline, but when time comes to implement it, we really have to work with EPIC engineers to make sure that there is a data flow from the EPIC, or the care system into the model so that we can actually predict and we can provide this. Otherwise, the provider has to enter the data by hand into some web tool. And if the data elements becomes large, then that defeats the purpose. So there is a lot of questions that we have to ask. Can we do NLP in real time? Can we pull the clinical data during the initial patient presentation? Do we have a stable patient population with rich longitudinal data to use that information to predict something that is happening at the time? And most importantly, do we have the buy-in and support from the IT administration and end users? Because at the end of the day, we want to make something that is going to be useful. And then there is the idea of evaluation, and we want to think about systematic evaluation versus manual chart review, available resources. Do we have nurse navigator who's going to look into the charts and basically part of the quality improvement project at the initial phase? And again, all these models, they need to be monitored and updated. We didn't know COVID would happen. So if the model was built pre-COVID, we have to test it out, see if COVID and the patterns of care utilization change. So we probably need to update some of these models after some time. All these AI-enabled assistive tools must address the challenges and limitations of EHR, big data, and the machine learning. I think we have to think of the future of healthcare is a blend of course, technology, innovation, but also human connection. So we cannot just think about technology and just ignore the human component of it. And it's not right to think about, we want to make care faster, better, more accurate. We also have to make sure that we are not favoring a certain group of population. We have to make sure that we can at least not have systemic bias in our data. If data is biased, the models are going to be naturally biased. So we really have to dig a little bit more, do our due diligence in that. So I'm going to skip this overview summarization to kind of talk a little bit about innovation in clinical trials. So there is not just application in the, a tool that goes into the EPIC, but there is also a lot of other application of AI in healthcare. So the clinical trial is very expensive and really drain a lot of resources for one approved drug. So the machine learning or AI can help at the different stages of this process. For example, streamlining drug discovery, guiding the patient enrollment, improving the scale of the design, and improving the continual monitoring and early termination. So I will not go too much in detail in this, but that's kind of an interesting area to think about. And then, of course, we can improve health disparity using the technology. We can improve, mine the clinical notes to better understand what patient actually need. when they talk to their primary care and then they discuss some of these personal experiences they have. We can improve the data by increasing the data footprint for patients who don't have access to quality care. We can increase the patient representation in clinical trials, and the list just goes on. So I want to leave more time for questions and discussion. I see that there are 2 questions, so let me read concerning admission. So in the readmission study, we really did a lot of different models, and actually the paper is published in Frontier Neurology. So we really look at, we only look at the past 3 years or so, because the way the Geisinger system implemented the stroke care changed significantly over the years after we joined. So we really did a lot of effort to make sure our data is as good as we can have it. And the features that were very comprehensive, we had 68 different features in that model. And for some of the features, when the count was very low, so we really kind of dig in and look at those patients to make sure that we don't have some spurious correlation with the outcome. So I don't know if that answers the question. Yeah, so that's a good question. What is the definition of AI? How is it different from machine learning and statistics? Some people say when you want to sell the idea, you say AI. When you want to actually do it, and you kind of are in the process of writing the papers and actually doing some of these things, is machine learning, because machine learning is basically you look at the data, you learn a pattern, you apply the same pattern to unseen data. So it's a learning process. And a lot of time, a simple logistic regression, which basically is a statistics, can do the job. So it's not always more complex models are better models. So it's really, I feel more effort should be invested in actually cleaning the data, harmonizing the data, make sure all the different factors are taken into account. There is so many packages that we can, just run the machine learning, but there is not a lot that effort that is going into prepping the data that I think it is worthwhile spending more time. I don't know if that answered the question. So, and then basically this is really a team effort. Genetic analysis. Zhangli does a lot of genetic analysis in the team. Venki is very expert machine learning programmer. Ramin Zad, my husband, also is our stroke doctor. And then we have very talented postdocs in the team, and a lot of students that, especially during this COVID, we did work a lot from home. So everyone is chipping in to help. And the picture below is before COVID. So, so I leave it for questions.
Okay, so maybe I'll jump in to ask 2 specific questions regarding the application you have. So one, you talk about the multiple imputation for handling missing data. So usually in statistics, we know like even though you do like a multiple imputation, there's still like assumptions behind it. So in real application, how would you assess whether the assumption behind the multiple imputation is correct, or how would you go about that when you implement multiple imputation?
So for the labs that have a lot of missingness, we noticed that the pattern is not always at random. A lot of imputation techniques assume random missingness, which is okay for the labs that have low missing rate, or sometimes But then when is very specific population, for example, A1C, if someone is pre-diabetic or overweight or has a family history of diabetes, the doctor send the A1C test. So, and a lot of these patients end up to be diagnosed with diabetes. If the test was sent to everybody, and then people would just randomly not go to the test, then the average or the distribution would be more shifted to the lower range. Because now we have a lot of younger patients, we have a lot of lower BMI patients that would have contributed to make the distribution of these variables. So what we saw that the patterns of comorbidities have some correlation with some of these labs. So for labs that have a high missingness, including some of these comorbidities as covariates in the model can improve in sometimes the prediction estimate for the actual lab that have missingness.
Okay, so you try to come up with a good prediction model for the missing data.
Mm-hmm.
Okay, I see. Thank you. Another question I have is that you mentioned you utilize a different sampling scheme to improve the prediction modeling. Can you elaborate that a little bit?
Yes. So sometimes the case control imbalance is really, so for example, we have, it happens for when we have a lot of controls and very few cases. Naturally, in prediction models, you in the training, you have only a few samples that have positives and everything else is negative. So there are these, there is a lot of published research, packages that we can use to increase the number of cases, bring them up and then maybe sample from the controls. So we can do different sampling. So if we have too many controls, we can sample from them, have a smaller portion of them. And then if we have too few cases, we can upsample them. And there is a smooth, there is rows, there is a multiple of these packages that we can use to play with the ratio of case control and see what works better in the specific example.
I see, thank you. Any other questions from the audience? No more?
Just one comment.
Oh, thank you, Vicky.
Okay.
Yeah, so basically, thank you for this time to present. I really like to know more about the team at Penn State, and looking forward to great collaborators. I already worked with a few people at the public health sciences, and it's really I had a very positive experience so far, and I really look forward to do some of this work here.
Yeah, sure. There are a lot of initiatives going on at the College of Medicine. Yeah, I believe more and more people, especially physicians and clinical investigators, they are looking forward to collaboration with people, experts like you, who can really help them to utilize all the existing EHR data to do to advance the research. Yeah. Okay. So it looks like we don't have more questions for our speaker. So I would like to thank you, Dr. Abedi, for giving such a wonderful talk. I really appreciate it. I learned a lot myself. So our last seminar for this semester will be in 2 weeks from now. It will be a talk on the implementation science. So we look forward to see everybody come back for that seminar. So now I'm going to end our Zoom session. Thank you, everybody, for joining us. Hope you all have a good evening. Thank you.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.